Good morning, ladies and gentlemen. I'm Dr. Haris Hassan Qureshi, and I've made this new initiative of teaching and training. And this is my YouTube channel, DRHHQ Teach, because I guess YouTube is a very easy access. Everyone has it on their cell phones and everywhere. So I am working as an associate professor at SIUT. Excuse me, I'm looking after the robotics over there and uro-oncology, and I'm treating stone patients. And I'm keen reader, and I have got an awareness channel named DR underscore HHQ that is for the public awareness. But now I have taken this initiative to teach and train you people in urology as well. So when we talk about urology, this is my first official video. So we have to start with the investigations. I have uploaded one video on history, and now this is the second video, which will be on urological investigations. So anybody has got any comments or queries, they can ask me. We will be discussing in the comments, or you can contact me in person as well. I'm most easily accessible person on social media. If you search Dr. Haris Qureshi on Facebook, Instagram, YouTube, TikTok, any LinkedIn, Twitter. So I'm available over there. So we'll be doing a bit of bookish things in this urological investigations. I'll be mostly focusing on the urine DR and CS, but we'll be in between talking about the exam comments and queries as well. So without wasting any time, let's talk about the learning objectives. We'll be talking about the urine detailed report cytology, and a bit about basics about these other things like PSA and other lights and everything, and why they are important and what can be asked in exam. When we'll be discussing about other topics like oncology, then we can cover PSA in that as well in detail. So, as this is the first video, so we'll start with the urine analysis. It is the most fundamental test, and whenever anybody asks you any question in exam, that how will you proceed? So the baseline investigations have to be answered, and in that you have to say CBC, blood CP, urea, creatinine, and electrolytes. Why we'll be discussing it, and then urine DRCS. CBC because you need to check the hemoglobin, and TLC count, WBC count, platelets, because urology needs that. And urea and creatinine are very important. A lot of patients are in failure. Along with that, you need to excuse me, you need to comment on lights as well, because in stone disease and a lot of other diseases like adrenals, there can be problem with the lights as well. So urinalysis is the fundamental test and should be performed in all urological patients with urinary complaints. If anybody asks me that you've got a flank pain, what investigations will you do? I'll say I'll get a baseline investigations, and then I will get a ultrasound, and this is how we proceed. So in baseline investigations, this urine analysis comes. So there's a physical and gross examination, dipstick, microscopic culture, and cytological examination. If a patient comes to you with hematuria, so the first thing you need to do is, if the patient is doing fine, you need to check that urine in a bottle. What is the color of that urine? So that comes in physical and gross examination, that the patient is having hematuria, or it is just that we think that the patient is having hematuria. So all about these samples should not be kept for long. They should be taken to the lab within 1 hour, and culture and sensitivity should be done along with DR, because otherwise the patient will come back again after 2 days that yes, I am having pus in my urine, WBCs, all those things going on, and it should be refrigerated at 5 degrees centigrade. So a bit about collection of urinary specimens. Male, it should be the first void morning sample. Midstream, clean your penis, and then midstream urine should be kept. Clean catch is a free of debris, and females clean midstream urine should be. In catheterized patients, the urine in the bag should not be taken. Something should be extracted directly from the Foley's catheter. And let's talk about neonates and infants. A lot of people ask this in exams as well. So there are sterile plastic bags. They can be used, and they can be a supra pubic done aspirate done as well. So these are the things which you can do in a pediatric patient, but you have to clean it up and then do all these things. Sterile urine should be taken, otherwise it will be contaminated, and then you will be treating the patient, which will be of no use. So talking about the physical color of the urine is very important. It is the color of the urine is light amber colored urine, but it can be pale yellow or colorless if very diluted. And there are a lot of products, medicines, infections changing those color of the urine. So they can be cloudy and milky urine and chyluria, phosphate urea, pyuria. A lot of people come with having pyonephrotic kidneys with very cloudy urine, and we judge that something is going on wrong with that urine. It can be red hematuria, hemoglobin urea because of excessive exercise. All myoglobinuria can be done as well. Lead poisoning, beets, rifampicin, we all know TB drugs can do that. Once I had a lot of beetroots, and my urine color also started changing. So I got a bit afraid. So hematuria is a red flag sign. So talking about orange, it can be dehydration or a drug called sulfasalazine, and it can be brown in beans, porphyria, chloroquine, metronidazole, nitrofurantoin, and it can be black in methyl dopahemorrhage or sorbitol. There's a purple bag syndrome that a lot of bacteria, they like urease and protease, they can cause that. And the urine bag, which is connected to Foley's, can have purple color in it. So there are a lot of colors going on in the urine, and they can be changed. Just at this point, I want to tell you that a lot of people think that these things are useless. These things are very important because now there are case-based scenarios. So everyone will ask, a 24-year male came with complaints of this. What do you think is going on in his urine? And these things can be asked. And in your vivas as well, these things can be asked. So odor is another thing. Ammonia, like urea splitting bacteria like Proteus, Pseudomonas, Nocardia, Klebsiella can be there. They can be foul smell. Old specimens, pus inflammation can cause that. Fruity in ketones. So let's talk about the chemical analysis. Quick and inexpensive result comes in 60 to 120 seconds. You just dip it in your urine, that dipstick, and it is highly sensitive, cost effective. And 10 parameters can be known in just a snap, like 120 seconds. That is a very short time. Excuse me, I've got bad throat, so you have to bear with me. So this is how the dipstick results come. Leukocytes, nitrates, urobilinogen, protein, pH, blood gas, specific ketones, bilirubin, glucose, all can be seen. So let's talk about specific gravity. It should be 1.008 to 1.020, and 1010 is a cutoff that the kidneys are working properly. 1010 means 1.010. It reflects the patient's hydration status, along with abnormal renal function and renal concentration ability. A lot of questions are asked that a person's PCN is placed. How would you know that the kidney is working properly? Number one is urine output. You can get a MAC3 scan, you'll know, and then you can get a specific gravity of that urine from the PCN, and that can give you some idea that how the kidney is functioning. So specific gravity is an important thing which is taken very lightly by all the urologists and urology residents. So if the specific gravity is 1.008, it's diluted, diabetes, renal tubular disease, increased fluid intake, or diuresis is being done. And if it is greater than 1.020, it is concentrated, like SiADH, glycosuria, dehydration. So specific gravity has got its role, and pH has got another role. The pH of the urine reflects what is going on in the serum. So you will have some idea. 4.5 to 8 is the range. 5.5 to 6.5 is the range. Acidic is 4.5 to 5.5. Alkaline is 6.5 to 8. And in metabolic respiratory acidosis, urine pH is acidic and vice versa, except in renal tubular acidosis, alkaline urine because loss of bicarb in blood. So these things are very important, and even in stone patients, you can have some idea with what kind of environment the urine has and what kind of stone the kidney is making. So pH is a very important factor as well. So, urea splitting organism, most commonly Proteus, convert ammonia into ammonium and elevate urine pH greater than 7.5. This is what I was talking about. And this causes precipitation of calcium, magnesium, ammoniate, phosphate crystals, which cause crystallization and then later stone formation. These are called MAP stones and infected stones and staghorn stones. Urinary pH is acidic in patients with uric acid and cystine stones. Alkalization of urine is very important in both therapies. So very important factor, hematuria. A lot of people say, what is hematuria? They see a urine DR report and they see one RBC or two RBCs, and we call it less than 3 RBCs per high power field is normal and sensitivity is greater than 90. Degree of color change directly to the amount of hemoglobin present in the urine specimen. The color of the urine is very important because, as I've shown you, that it can be changed in a lot of things. So hematuria is a complete field, and in my history taking video, which is placed on this channel, you can have some idea that what questions can be asked in history, and in your long case, those questions can be asked. Hematuria can be distinguished from myoglobinuria, hemoglobinuria by microscopic examination of centrifuge urine by presence of RBCs. False positive results, menstruation, dehydration, vigorous exercise can also cause it. Hematuria with nephrologic origin is frequently associated with casts in urine, and we'll be talking about casts and crystals as well, and almost associated with significant proteinuria. Urological causes of hematuria is unlikely to elevate protein concentration in urine into 300 to 300 is a milligram per deciliter is a normal range. And on your report, you can see 2 plus or 3 plus. Then glomerulotubule intestinal origin can be should be excluded. Dysmorphic shape of RBCs on microscopy is indicated hematuria from glomeruli origin, while urological cases and tubulointerstitial cases are uniformly round shaped. So if they're round shaped, you can think about some urological. And a lot of times we get a dysmorphic test of RBCs on microscopy to rule out those, that why the patient is having hematuria. Anticoagulants play another role, but these things in the urine DI you won't be able to find. You'll only find that there is bleeding going on. Causes of hematuria, there are a lot of causes of hematuria from kidneys to bladder. But if you ask me that a 70-year-old male comes to you with hematuria, then it is bladder tumor until proven otherwise. If a 20-year-old comes with hematuria, it can be UTI. So age, history matters a lot. You have to diagnose those things in your MCQs. There will be hints given. You have to read them and find those hints because they are very important. And these are the list of cases which can cause, they can be painless hematuria, painful hematuria. So if painless, tumor comes first. If painful, then stone comes first. There are no two school of thoughts about it. A bit about proteinuria. 80 to 150 mg per day is the range. 30% albumin, 30% globulin, 40% tissue proteins. Majority of them are Tam-Hornsfield proteins. Urea can be the first indication of renovascular glomerular interstitial disease. A lot of patients message, and one of my videos on YouTube on health awareness got viral about proteinuria. So I realized that a lot of patients are having proteinuria and this goes undiagnosed. So if you get a urine DR test done, so you can evaluate and differentiate between urological case and a nephrological case. So bit about nephrology is also needed in the exam to get good marks. It's all about kidneys. So kidneys is a kidney. So overall, abnormal proteins can be seen in multiple myeloma MM as well. So proteinuria can be categorized into three categories. Glomerular proteinuria commonly results from increased glomerular capillary permeability to proteins, specifically albumin. 24-hour protein is 1 to 3 gram. Then comes tubular proteinuria, and then comes overflow proteinuria, absence of any renal disease caused by increased plasma concentration of IgA or Benz-Jones proteins like in multiple myeloma. False negative results can occur in alkaline urine, diluted urine, and primary protein present in is not albumin. So a lot of tests can be done. A 24-hour collection can be done, and you can find immunoassay is another method of detecting proteins such as Benz-Jones proteins in multiple myeloma as well. So evaluation of proteinuria is a bit complicated, and over here you can see that it can be transient, it can be persistent or intermittent. In urology, they won't be asking you this in this detail. This is pure nephrology, but you should have some idea that you need to get first you have to get the serum proteins done, and then you have to get a 24-hour protein done if the serum proteins levels are somewhat abnormal. So over here, you can see how to go about it. I don't want to go in this detail because a lot of people think, and yes, proteinuria is a bit nephrological, but you need to know a bit basics about it. Glucose and ketones is another important thing. Glucose becomes too much, it crosses those glomeruli, and it can come in your urine. You see a lot of patients with diabetes, they have urine glucose coming in their urine. So renal threshold corresponding to serum glucose is about 180 mg per deciliter. Above this level, glucose will be detected in urine. So this is the cutoff, and a lot of people send me their urine reports, and they've got glucose, and they in their urine, and they get diagnosed for diabetes by this. Ketones are usually not excreted in urine. If there is abnormal fat breakdown, then you can find those ketones coming, and it can become these glucose can be coming in diabetes, diabetic ketoaciduria are the causes. Bilirubin and urobilin normally they don't normal urine doesn't contain bilirubin, contains only small amount of urobilinogen, and false negative result can presence occur in a presence of ascorbic acid, jaundice, hepatic, extrahepatic can be caused. So if urobilinogen is coming in your urine, so you can have some idea that something related to hepatic problem is going on. So a lot of examiners ask these things in detail. Don't take them lightly. So you should be having some idea that what is going on. Leukocyte esterase is another activity which can show you that there is infection going in your urine and presence of WBC in your urine. A lot of people ask that if there is infection going in your urine, what will you find? You will find nitrates positive, leukocyte esterase, and you can see those pus cells, WBCs even that can cause hematuria RBCs as well. The sensitivity of tests decrease with time because of lysis of neutrophils. So as I told you, you get a urine test and send it for testing ASAP, as quick as possible. And leukocyte esterase can be seen in contamination as well. If you find nitrates in your urine, it is because of bacteriuria. There is some infection going on. A dipstick is positive for leukoesterase but negative for nitrites. Non-infection causes of inflammation should be considered. Inflammation is a very big problem. So the specificity is 90, more than 90, but sensitivity is 35 to 80. So it can vary. You have to look in toto everything, but this gives you an idea that what is going on. You need to know non-infectious causes of the nitrites are positive and negative, and leukocyte esterase is positive. If it is less accurate, if urine specimen contains less than 10 raised to the high power organisms per ml. Microscopic examination is 10 to 15 ml of urine centrifuge for 5 minutes at 3000 rpm. And this segment is taken to glass slide for microscopic examination. Low power magnification is done, and erythrocytes, leukocytes, CAS, cystines, parasites, schistosomia, hematobulum, Trichomonas vaginalis, all can be seen in high power. The shape of RBCs, type of crystals identify the bacteria and yeast. This is a very important slide. A lot of examiners ask that you have taken a urine sample. Now, what will you do and how will you find it? So this is what is need to be answered. And if you answer these things, then nobody can give you bad marks. So cells, cast, crystals, bacteria, yeast, parasites should be done for urinary sediment examination. So talking about cask is a protein coagulum that is formed in the renal tubule and traps any tubular luminal contents within the matrix stem Holtzwheel microprotein. There's no clinical significance, but still cast can show you that something is going wrong nephrologically. RBC cast contain entrapped erythrocytes and diagnostic for glomerular bleeding, most likely glomerulonephritis. So as I told you, hematuria can be because of a lot of causes, and to rule out those, you need to know a bit about cast as well. WBC casts are involved in infective process like acute pyelonephritis and glomerulonephritis. Fatty cast cells are seen in nephritic lipiduria and hypothyroidism. So, identification of crystals in urine is important for stone disease, which helps determine the etiology. Identification of crystals establish the diagnosis of cystinuria. Crystals precipitated in acidic urine are calcium oxalate, uric acid, and cysteine. As crystals precipitated in alkaline urine are calcium phosphate, triple phosphate crystals. So these are the bookish things about crystals, that why and how are crystals formed in which stones and which conditions. Shape of these crystals are very important. Calcium oxalate stones can present with octahedral, and calcium phosphate stones can present with dumbbell shaped, and cysteine stones can be hexagonal. As you can see, these are microscopic things. They can be asked in exams, vivas, and along with that, you need to know to be a good clinician. You need to know these things. Otherwise, in MCQs, this can come as well. So triple phosphate stones are coffin lead shape. So this is a brief summary that how these, you can see that I've just told you that what are the shapes of these stones: calcium oxalate, monohydrate, cysteine, hexagonal, amorphous, spokey. So a lot of shapes are there. So you need to know that what is going on related to this microscopy of crystals, because the shapes can be asked and a bit of pathology can be asked, which is present over here. So talking about bacteria, normal urine has no bacteria, and uncontaminated specimen finding bacteria is indicated of UTI. So on high power field view, between 1 is to 20,000 or 1 into 50,000 per ml is significant. Each bacterium seen high power field signifies a bacterial count of more than 30,000 ml per ml is important. Therefore, 5 bacteria per hive power field reflects colony count of about 1 lakh per ml. So this is the significance of bacteria in your urine. Yeast can be seen. Candida albicans can be found in it. It is biconcave, oval-shaped yeast and can be confused with erythrocytes or calcium oxalate stones. But this is a very important thing. How will you differentiate between yeast and other things? So it is biconcave, oval shape can be seen. They have budding and hyphae, so they can be distinguished by that as well. Urine for cytology is requested when urothelial malignancy is suspected, and however, radiological investigations have become so better that now this cytology is not that much indicated, but you need to know about it. We'll be talking about it in detail when we're talking about malignancy. It is highly specific for high-grade urothelial carcinomas of bladder, upper tract, and sensitivity decreases for low-grade urothelial carcinoma. The main question is, if this comes negative, can there be a tumor? Yes, there can be a tumor, and if it is a low-grade tumor, that can be missed on it. So when we'll be talking about this. In cytology in detail when we start our bladder and urothelial things, but you need to know that there's a pale blue cytoplasm and dark nuclear hypochromatic purple can be seen, and that is squamous cell carcinoma in urine. So we'll be taking a class on these microscopic things as well, because now in your talks exam they ask about that as well. And now, eventually, after those computerized exam coming in your MCQs, this picture can be placed out. There can be a question, and there may be shapes of crystals can be present over there, so they can be present as well. So I have briefly described that why you want to get these tests done. Serum calcium and serum uric acid levels are very important in a patient of stone disease, so you need to get them done, because a lot of stone things are, if the serum calcium is raised, then you need to do a PTH, parathyroid hormone, as well. Oxalate and cysteine levels can be done, not in every patient, but yeah, if there is something shady going on, then you can done a metabolic study of urine. Genetic study for hyperoxaluria can be done as well. PSA is an important, we'll be discussing PSA in detail when we talk about prostates, but a bit about PSA. It is a glycoprotein in the kallikrein family produced by prostatic luminal epithelial cells. These questions don't come directly. There'll be a scenario like a 70, 60-year-old male with a back pain and things like this going on. So a statement will be that it's produced by prostatic luminal epithelial cells. So indirectly, these kinds of things come in your MCQ. So you need to be alert regarding it, and you need to know from where the things are produced. Serum PSA measures the PSA in circulation. Total PSA equals to free PSA plus complex PSA. Complex PSA is bound to other proteins, mostly anti-alpha-1 chymotrypsin. PSA's half-life is 2.2 to 3.2 days. It's an androgen-dependent production stimulated by androgens. PSA is not capable of diagnosing prostate, can only estimate the risk of prostate cancer. This means that if somebody has a normal PSA, they can have a prostate cancer, and somebody has a raised PSA, maybe they don't have a prostate cancer, because PSA is raised in a lot of things, and elevated PSA can be prostate cancer, BPH, infections, prostatic manipulation by trauma, DRE, ejaculation, intercourse. PSA increases with age as well, and reduced PSA can be by alpha blocker like 5-alpha reductase, reduce the total PSA by 50% 6 to 12 months, but doesn't alter the free PSA. Low serum testosterone, prostatic surgery, prostatic radiation, hemodialysis do alter free PSA, but not total PSA. So in an equivocal case, you can get a free to total PSA. Like if the PSA is from 4 to 10, you can get a free and total PSA. But MRIs have become very good, so they can be of very helpful. VMA is another investigation done in urology, catecholamine testing. So we'll be discussing in detail when we talk about the adrenals. Catecholamine, dopamine, norepinephrine, epinephrine are produced by pheochromocytopenia. Varying amounts release of these compounds into bloodstream is often paroxysmal. Metanephrine testing together, normetanephrine and metanephrine are known as metanephrines. Metanephrine testing is very important, and the conversion of catecholamines to metanephrine in an uninterrupted process within few chromocytomas. Measurement of plasma concentration of metanephrines is a much more sensitive means of tumor detection than measure of rises of plasma catecholamines, which can be paroxysmal. So metanephrine is more diagnostic of any adrenal problem going on, adrenal tumor going on. Vinyl mandelic acid is another modality, primary end metabolite for catecholamine synthesis of VMA requires catecholamines or their metabolites by the enzyme MAO, and occurs not only in adrenal medulla but in sympathetic nervous system as well. Therefore, the relative rise of VMA levels in the presence of pheochromocytoma is much less dramatic than the rise of metanephrines. So its sensitivity is a bit less, 65%, so you can miss it. The specificity of this test is high, especially in non-familial cases, but metanephrines have got an advantage. A lot of people ask about AFP. We'll be talking about this in our testicular tumor series when we'll reach there. So there's AFP, yolk sac tumor of testis, beta, HCG, choriocarcinoma, prolactin, testosterone, FSH, LH can be altered in hypogonadism. So this was a first video, a very basic video and a very dull topic, dry topic, because there is no, a lot of people take it lightly that what is the use of teaching this? This is the basic. When you go for your vivas, you do your long case, short case, then you go to investigations. Over there, you get stuck. On your MCUs, you get stuck. So these are very important things, and feel free to message me, contact me, any queries, anything you want to know, because I'm ready for there to help. I'm easily accessible on this channel over here, DRHHQ Teach. This video will be uploaded over there, and you can message me on Instagram, dr_HHQ, and this is my social media handle everywhere, on Instagram, Facebook, and Twitter, LinkedIn. So feel free to message me. This was the first basic video, and we'll be having a series of these videos. I'll be trying to upload a video per week that you people can get advantage out of it. Please give your feedback in your comments, and share it with all those people. Whenever I go for the exam throughout Pakistan or abroad, so they all ask me this question: why don't you make videos for us? So this is the first video. Thank you very much. Stay tuned.